So when you're thinking about complications of diabetes, we also have to look at those chronic issues. Angiopathy, diabetic retinopathy, nephropathy, neuropathy, complications of the feet and lower extremities, integumentary complications, infection, and psychological considerations. So when we're thinking of angiopathy, we're really thinking of those end organ disease from damage to the blood vessels secondary to chronic hyperglycemia. It is the leading cause of diabetes-related deaths. There's two main categories. Macrovascular, where there is disease of large and medium-sized blood vessels, and this is going to be cerebrovascular, thinking of like stroke, cardiovascular, heart, peripheral vascular, like the PAD and PVD we talked about. And then there's also microvascular. And this is when there's thickening of vessels in the capillaries and arterioles. And specific to diabetes, we're going to see things like retinopathy, where the eyes are affected, nephropathy, where the kidneys are affected, and neuropathy, when the nerves are affected. With angiopathy, we really need to try to have good glucose control. Want to get them to quit smoking if they are a smoker, good blood pressure control. Want them to participate in screenings for cardiovascular complications yearly. Ideally, they should be on a statin, secondary to abnormal lipids, and we're going to want to be treating if they have insulin resistance with appropriate medications and diet and exercise. Now, with diabetic retinopathy, there are microvascular changes to the retina. It most commonly causes adult blindness. The earliest and most treatable states of diabetic retinopathy may not produce changes in the vision. You do need to have a dilated eye exam at the time of diagnosis with type 2 and then yearly after, and for type 1 within 5 years of diagnosis and yearly thereafter. And if you think about that, why does somebody with type 2 need to have it right away and then yearly after? Remember, they have probably had hyperglycemia for a long time before they get diagnosed, versus somebody with type 1, although they may have had those antibodies, once they don't have enough insulin, it's pretty rapid. And again, so prevention is going to be tight glucose and blood pressure control, and they can do laser photocoagulation, and that is used to reduce the risk of vision loss. So with diabetic nephropathy, there are microvascular damages to the blood vessels that supply the glomeruli of the kidney. It is the leading cause of end-stage renal disease in the U.S. Risk factors also include hypertension, genetic predisposition, smoking, and chronic hyperglycemia. A patient should get yearly screening, and they should get a spot urine collection to assess for albuminuria. And that measures the amount of albumin-creatinine ratio. And if you remember, I've talked several times this semester about, when the kidneys are spilling protein, we know there's a problem. And albumin is a protein. So if we can check this albuminuria, they're going to get a quicker idea of kidney issues even before we start seeing BUN and creatinine changes. They also, of course, need to have the creatinine checked. If albuminuria is detected, the patient will be prescribed an ACE inhibitor or an ARB, angiotensin II receptor agonist. As we talked about previously when we talked about hypertension, we know that ACE inhibitors help to protect the kidneys, and they delay the progression of neuropathy or I can't even get it out, and diabetes, and then stringent control of blood pressure and blood glucose. Diabetic neuropathy is when there is nerve damage secondary to the metabolic derangements associated with diabetes. The most common is sensory neuropathy, and it leads to the loss of protective sensation in the lower extremities. It increases risk of lower extremity limb amputations, and screenings for somebody with type 2 diabetes should happen and within 5 years for type 1. So somebody with type 2 should start right away, and then somebody with type 1 should be checked within 5 years. So sensory neuropathy is the most common. This is when somebody has it in their hands and feet bilaterally. Stocking glove neuropathy, where there's loss of sensation and abnormal sensation, pain, and paresthesias. Pain is often described as burning, cramping, crushing, or tearing. It's usually worse at night, but occur at any time. Paresthesias is when somebody has a tingling, burning, or itchy sensation. It can feel like walking on pillows or on numb feet. Skin can become very sensitive, and the sensation, they may have complete or partial loss of touch and temperature, and there can be atrophy of the small muscles of the hands and feet. So sensory neuropathy, we really want to try to have a good glucose control. There are some drug therapies such as topical creams, tricyclic antidepressants, SSRIs, and norepinephrine reuptake inhibitors, anti-seizure medications such as gabapentin, and again, that is the one I see given the most. And medication therapy may increase symptoms initially, but then it should have some relief in about 2 or 3 weeks. Now, autonomic neuropathy is when it can affect all body symptoms, and this can lead to hypoglycemia unawareness. The patient may start having some bowel incontinence and diarrhea, urinary retention, gastroparesis, where there's delayed gastric emptying, anorexia, nausea, vomiting, GERD, and persistent feelings of fullness. It can trigger hypoglycemia due to the delayed food absorption, and then metoclopramide can be given prior to eating to help with that. With autonomic neuropathy, there can be cardiovascular problems such as postural hypertension, neurogenic bladder with urinary retention. With men, there can be erectile dysfunction. Women may have decreased libido, and nonspecific or candida vaginitis. Complications of the feet and lower extremities. Patients with diabetes have a high risk for foot ulcers and lower extremity amputations. And this is a result of micro and macrovascular issues. So that's that sensory neuropathy, they can't feel things. The PAD, meaning we get less blood flow down there, possible clotting abnormalities, impaired immune function, autonomic neuropathy, smoking, loss of protective sensation. In Charcot foot, where there are ankle and foot changes that lead to joint dysfunction and foot drop. So integumentary complications would be diabetes-related dermopathy. It is the most common diabetic skin lesion. It's characterized by reddish brown, round or oval patches. Initially it looks scaly and then it flattens out and becomes indented. It most frequently appears on shins, but can also be found on the front of thighs, forearms, side of the foot, scalp, and trunk. Another thing you might find with the skin is acanthosis nigricans, and this is a manifestation of insulin resistance, and it's where you get this like light velvety brown to black skin thickening, specifically in the body folds and the neck or axilla. Of course, patients with diabetes are more susceptible to infection. They have an inability to mobilize their WBCs properly. They're more likely to get Candida albicans, yeast, recurrent infections. They might get boils or furuncles, which is a skin abscess caused by staph involving the hair follicle. They have a loss of sensation, which may delay the detection of an infection. They have persistent glycosuria, meaning there's glucose in the urine, which puts them at risk for the bladder infections. They need to get annual flu shots and try to avoid people who have communicable diseases. Patients with diabetes have high rates of depression secondary to decreased ability for self-care. They may feel helpless related to their chronic illness and poor outcomes. They may have anxiety, and they could even have an eating disorder with type 1 and type 2. And these eating disorders could be anorexia, bulimia, binge eating, excessive restriction of calories, or intense exercise. With our elderly patients, we need to know that there is a higher rate of premature deaths. They're more likely to have functional disability. They often have coexisting illnesses such as a stroke or hypertension. The prevalence of diabetes increases with age, and undiagnosed, untreated, or undertreated occurs more often in the older population because of normal physiological changes of aging can resemble those of diabetes, such as like that low energy levels, falls, dizziness, confusion, and chronic urinary tract infections. So with our elderly, some of the things we want to consider when they are determining glucose goals for them: the hypoglycemic unawareness is more common. The delayed psychomotor function, which they might not be able to treat their hypoglycemia in a timely fashion. The patient's desire for treatment and coexisting medical problems, meal planning, exercise. We need to assess their renal function and creatinine clearance. Their manual dexterity may be compromised, which makes it more difficult for them to do insulin injection. And then the patient education that would need to take place.